And thank you for your extraordinary work on behalf of Alzheimer's patients. A couple of questions that I'd like to just raise. Do any of our panelists have a sense as to where, everyone asks me in my district, and I get this every time I'm out on the road, particularly when I'm speaking about Alzheimer's, how close are we to a breakthrough on delaying early onset, certainly recognizing it, but the drugs that are in the mix, that are in the pipeline, is there reason for serious hope that we may be many years away or maybe just a few? What's your sense on that?
I'll give you a view, but I would be very interested in both the association and Andrea's view, because this is obviously unscripted. There are several drugs in late stages of development in the pipeline. They are targeted at mild to moderate cases of dementia and have not yet been targeted to earlier cases, at least in the current late-stage trials. And they are showing a modicum of possibility that we could slow down the rate of decline. Those drugs are going to be finishing those trials in the roughly 2015-2016 timeframe. They will be before, if those trials are successful, before the FDA in the 2016-2017 timeframe, and it is possible that we will have a first-generation drug for mild to moderate victims of this disease in that time frame. The world, as Dr. Pfeiffer has laid it out, has now begun to shift its attention to earlier stages of the disease. So the same drug that's now in trials for mild to moderate dementia is now going into trial for much earlier stages of dementia. And if those prove successful, then we will have a drug on the market that may be potentially administrable to patients before they get any signs of cognitive or functional decline. And sort of on the current timeline, that would probably be in the 2018 to 2020 timeframe. But I have always treated it as the metaphor of what happens when you try and introduce a new product. The first time you get a new product, it is clunky, it is expensive. The second generation of that product is better. It will be less expensive, it will be more effective. So while I think there is reason for confidence that by 2020 we will have a drug on the market that will have a modest effect on the progression of this disease, I think that the likelihood, the prospect of getting a truly effective means of prevention and treatment is possible, perhaps even likely by 2025, but quite frankly dependent highly on funding and focus between now and then. So I think this is not something that by 2025 it's going to happen with business as usual. It is going to require increased focus and increased resource in order to get us there.
Thank you.
I would say I'm cautiously optimistic, but I would underscore what George said at the end of his statement. I think that the scientific community has the ideas, the will is there, the technology is there. What is lacking is the level of resources and the commitment that's necessary to get us there. And so I'm optimistic that we can, but it will require a greater commitment. The national plan, as you know, includes a goal of effectively treating and preventing Alzheimer's by 2025. There will be interim steps. There will be interim progress. And one of the great developments of the national plan so far is that the National Institutes of Health finally has a blueprint, it has timelines, and it has a milestone for us to reach that goal. And so I think the question now is whether we will, and the government will come through with the resources that are necessary.
Dr. Pfeiffer, did you want to speak to that?
Yes, I just would like to add maybe one aspect which I consider as enormously important for the progress we need, as it was mentioned by George and previously also by myself. The world is changing from intervention treatment trials to prevention trials, because obviously the biggest impact on society would be if we could actually prevent the disease rather than treat the disease. Now, as we all know, there is no diagnostic means today available which would allow us to actually select the patients which would eventually get the disease. So the only way to do that is actually to work with genetically predisposed population, like for example the Colombia population, in order to really test if prevention is possible. So my wish, my dream would be to have concerted actions and funding to support research which towards biomarkers and better diagnostic means, because only if we can in fact enhance the early diagnostic, so diagnostic before the disease started, only then we can really think about prevention trial, which would really change the world. So we need more funding for doing research in this important area.
I'd just add, Mr. Chairman, that the greatest obstacle to progress after funding is the number of people who are not participating in clinical trials. We need a lot more participants in clinical trials, not only those with the disease, but when it comes to things like prevention trials, we need healthy individuals to enroll in clinical trials as well. And I know there's some efforts underway, and the Alzheimer's Association has a trial match program to try to encourage this, but efforts by the government to encourage greater participation in clinical trials is also important if we're going to get there.
You know, as I think we all know, the UN estimates for growth in population is almost always about aging. You know, when we climb to 9 billion or thereabouts, maybe even 10 billion, it's not about children, it's about aging, and people are living longer. Which is all the more reason why the call and the action plans have to be put into place now as never before, and which is why we're having this hearing. I wanted to ask you a couple of very quick questions. We have an hour's worth of voting on the floor that just started, so I'll ask a few questions and yield to Mr. Weber, because I don't want to have you sit here and wait a full hour. But the amount of money, the $1 billion that you mentioned earlier, Mr. Vandenberg, we have tried, as you know, for years, and we worked very closely with both of you, frankly, to try to get the Breakthrough Act passed, to get it up to at least $750 billion of NIH funding, and we fall far short all the time, despite Herculean efforts, bipartisan to the core. How many good, and Dr. Pfeiffer, you want to speak to this as well from the European side, how many laudable proposals fall off the table at NIH or any other research facility or funding mechanism because the money isn't there? You know, I remember hearing that one estimate was like 3 out of 4. So we're missing the opportunity.
And the only reason that it is even that high is that the NIH has cut back the amount of those grants so that the numbers, so that they don't, if you in fact took the level of grant that was several years ago, the number of approved grants would be under 10%. So we're talking about a situation where 1 in 6 or 7, perhaps 1 in 10, depending on the size of the grant, is currently been approved. And those are peer-reviewed grants that are found to have been meritorious. To your point, Mr. Chairman, one additional point. This is beyond a health issue, as just pointed out with about-effective aging. At our recent Alzheimer's Disease Summit, the Path to 2025, that we conducted in New York, a member of the Japanese cabinet came to speak. And her country is beginning to shift its entire economic strategy from one of manufacturing to one of service, because they're not going to have enough workers at working age populations in order to support their manufacturing economy. So over a period of years, they're having to shift their entire national economic strategy to less labor-intensive jobs, jobs that can be performed by older individuals and potentially even older individuals from their homes. So this is not just, this is an issue of health, as Matthew has pointed out dramatically. but it's an economic imperative for countries as their age shifts. Western Europe is going through this in spades and how to adjust to this. And of course, the entitlement cost spending going through the roof, because, in part because of this, suggests that this is a fiscal issue as well. So it's a health issue. We have not been able to yet to engage economic ministers and finance ministers in understanding the import of an aging world on the shifts in relative economic strengths of different countries. You've seen China change its policy on the one-child policy because it foresees itself running out of workers in 20 to 30 years. So they're beginning to adjust their social policies to respond to the demographic changes that you just referred to. So this is a significant, a very, very significant thing for the relative economic power of countries around the world in the coming 2 to 3 to 4 decades.
Ms. Weber.